Hello, students. These are some additional slides for week 1. We reviewed the neuroanatomy, and these slides talk about what might happen in case of injury. Okay, so as you recall, we talked about how the bones of the skull, for example, were important in protecting the brain. However, the characteristics of the bones were that you see some irregularities, some sharp edges, and the potential for injury if there was ever any violent movement of the head. So in a case of a traumatic injury, the brain itself could be injured from scraping on the bones of the skull. So this is just a picture showing you those crevices, also the opening for the foramen magnum. And we mentioned again that because the brainstem and the upper area of the spinal cord is going through the foramen magnum, if there's any swelling or any twisting, then that's another potential area where there could be some damage. Another shot of the skull itself, and if you take a look at the parietal bone, the occipital bone, especially the bottom of it with the foramen magnum. You can see inside again the rough edges and the opening. So we talked about how the meninges are tightly adhering to the brain and the spinal cord so that there is no space in between. And in a normal situation, everything is a closed system protecting the brain. However, if there is some injury, there's a potential to have space occur, and within this space, there can be a collection of blood or CSF. So if there's a collection of blood between the cranium, that means the bone, right, the skull, and the periosteal layer, the periosteal layer is the outer layer of the dura mater. Okay, so if there's a space between those two, then that's called epidural space. And you can also have space that's subdural between the dura mater and the arachnoid, and you could also have subarachnoid. So you may hear about subarachnoid hemorrhage, for example. And then this, in this slide, we're also mentioning again the meninges and the fact that it's also tightly adhering to the brain. And because you have this tight membrane that's separating the two hemispheres, even separating the areas between the cerebellum and the occipital and temporal lobes, and the falx cerebelli, even separating the two cerebral hemispheres. Because these membranes are so tight, for example, the falx cerebelli could act as a guillotine and sever the midbrain or the brainstem if there was any shifting of the brain tissue. This is an actual dissection. So what we're looking at here is the left hemisphere has been removed. You can see right in the middle, this area here. I think you can see my arrow. That's the corpus callosum that's been severed. So the right hemisphere is still there. The left hemisphere has been removed. And remember, we talked about the different areas of the meninges or the dura mater. And this is the falx cerebri separating the hemispheres. So again, see how tight, thick this is and tough this is. And then the tentorium cerebelli here. So these are, again, areas of the dura mater that are tight and could cause some issue if there's swelling of the brain. This is a drawing of the falx cerebri and the tentorium cerebelli. Again, just showing how it adheres to the brain between the hemispheres, and then under the lower area, under the occipital lobes and then separating it from where you have the cerebellum. So if you take a look at this slide, I typically ask students to tell me, take a look at this picture and try to interpret what you see here. So as you're looking at this, I'll go ahead and explain. You'll see that there's bleeding that has occurred here in the brain. Is this epidural or subdural? No, this is actually intracerebral because it's right in the deep tissue of the brain. And you can see that because this bleeding is occurring, there's no place for the blood to go, so it's going to press on brain tissue. You can see that it is pressed onto brain tissue. You see on this side where this is the lower area of the temporal lobe, and you can see here where this portion of tissue is pushed through. If a portion of tissue is pushed through to another area, that's called herniation. So you can see that there. And this herniation is actually pushing through this area of the tentorium cerebelli, intact on this side, tight here, and then on this side. And the reason that it's, then also pushing on the brainstem, right? And you can see that the brainstem is now asymmetrical. So you're having tissue being compressed, and again, if you have compression on this tissue without any relief, then those brain cells, that brain tissue is going to die. You can see that this is impacting on the brain stem. Okay, all right. So in a traumatic brain injury, there are actually two stages. There's the primary that occurs and then the secondary. And what we mean by primary is, boom, there's been an injury that's occurred. There was a crash. The head has been shaken violently, contra coup. It's hit the airbag and bounced back and hit the headrest in the back. Or a person has taken a blow to the head, has been hit with the bat, or there's been a gunshot and the bullet has gone to the brain. Those are all primary. It's already happened. There's nothing that can be done about that. But what happens after that in terms of the damage to the brain, that's what's referred to as secondary damage. So with this primary thing, as I mentioned, that's the initial impact, and it can be closed or penetrating. So as I mentioned, you see different examples there. So a gunshot wound would be penetrating. Closed would be if there's an accident and the head hits the dashboard or the airbag. There could also be twisting or shearing forces. So it may not be a shaking front to back. It could be that it's a twisting movement that occurs. And one thing that occurs that's very significant is this diffuse axonal injury, and we'll be talking more about that. But if you think about all of the neurons in the brain, every neuron is going to have an axon, and in the event of injury, you can actually have sharing of those axons for the neurons. And we have a graphic to show a little bit of that coming forward. Okay. Also, if there's penetration, in addition to the actual impact, you would have destruction of tissue. Again, imagine a bullet going through the skull and into the brain and destroying all the tissue in its path. You could also have something like an ice pick, unfortunately, that could penetrate the skull and the brain as well. So this diagram is important. Let's see if I can shift the screen. Okay, good. So you should be able to see here at the top of the screen where it says primary damage from TBI. So all of the things that we just talked about, and this is an overview of the different types of ways that the brain can be injured. So it can be closed or penetrating. If it's a closed head injury, it can be acceleration or non-acceleration. If it's penetrating, it can be high velocity, and a bullet would be an example of that. Low velocity would be something like an ice pick. So enclosed head injury with acceleration injury, so I'm going to focus on that. You can have linear, which is that front to back. You imagine the head going front to back in a car crash. You can have an angular acceleration where there's more twisting of the brain in the skull. So imagine a fall where it's just not, a fall from a tall building and the body is twisting. Or it could be that's a car crash and the car flips over. So there's a twisting that occurs. So this is just explaining what happens in acceleration, deceleration, and then in these two instances. So I want you to go back and just really look over these and take a close look. But the linear is the one that we think about a lot in terms of this coup and contra coup, where the head goes forward, the skull hits the front of the skull, the head moves backward, the back of the brain hits the skull. I hopefully said the front of the brain hits the skull when it goes forward, and then the back of the brain hits the skull when it goes backward. And then, of course, if it's angular, if there's twisting and turning, you also have that shearing that we talked about. With non-acceleration, this would be, an example would be a bat hitting a head. And I know these are gruesome examples, but I remember working very specifically with a young woman. I was seeing her for home health, and she wore a helmet, and unfortunately she had been hit with a bat to the head. So anyway, with this type of injury, the meninges, there can be impression trauma. So that's at the site of the trauma. So where the bat hit, for example, then you can have damage in that specific area where the impact occurred, but then you can also have negative pressure with the rebound of the skull. So if you think a little bit about maybe want an aluminum can, and you sort of press it in a little bit, and then when it pops back out in that same spot, that's what it means by this negative pressure when the rebound of the skull. Ipsiloidal is when the impact really deforms the skull so that instead of an oval shape, that it becomes more, instead of a circular shape, it becomes more oval because of the impact. So you get stretching and tearing because of that. Again, I want you to go back and take a look at this, but this gives you different examples of the type of primary damage that can occur. I'm going to go to the next slide and talk about secondary damage. So because of what we saw in primary, there's nothing that can be done. This is when that golden hour is important. This is why they have developed emergency trauma treatment to such a high extent and saving so many people's lives, because getting to the person quickly, getting them the right EMT team, getting them into a helicopter that can take them, to a shock trauma type unit, is what will really save the person's life, and to really minimize these secondary things, the secondary things that can occur. So hemorrhage, cerebral edema, intracranial pressure changes, which is usually increased pressure, hypoxic ischemic damage, and seizures. Also, again, diffuse axonal injury. And we'll take a closer look here on the chart. So this is the same part of the chart. The other was primary, and now showing secondary damage after those primary things that we saw earlier. So for hemorrhage, remember we talked about how we can have epidural or subdural. So extracerebellar means that bleeding sort of above the brain, and then intracerebral is that bleeding within the brain. So that picture that we showed that showed intracerebral bleeding, and then we're going to show another in a second that has extra cerebral bleeding. So you can also have cerebral edema, which is collection of fluid. So it's fluid, swelling. You can also have intracranial pressure, as we said, an increase. Remember that you're going to have these, oops, sorry, that's my dog Nayla barking. I'm going to pause for a second. Okay, sorry about that little bark break there. Okay, I believe I was talking about intracranial pressure and how that can, that can increase. Remember, we talked about the ventricles and the ventricular system, with the ventricles being filled with cerebrospinal fluid, all of that being a closed system, all of that being under constant pressure. But if we have brain tissue that is pressing against the ventricles, it can cause a blockage of CSF and cause increased intracranial pressure. Hypoxic ischemic damage. Hypoxic refers to oxygen. Ischemic refers to blood flow. So because of tissue damage, tissue displacement, all of the other things that we just mentioned, then we're going to have reduced oxygen and blood supply to the brain, and then various results from that. And all of these things, a secondary effect of traumatic brain injury, can cause seizures that occur for an individual that might be early on. It can also occur later on. So again, this is a chart that we really want you to have a good look, to really read through, to have a good understanding of primary and secondary damage and know the difference between the two. Okay, so we mentioned earlier how you can have bleeding that occurs or space that occurs between the different layers. So here's an example of epidural hematoma. So this space has occurred between the cranium and the outer layer of the dura mater, and so that's epidural hematoma. And then here, bleeding has occurred below the dura mater and into the arachnoid space, so that's subdural hematoma. And just showing you two examples. Also, imagine that with this hemorrhage, this hematoma, you have this whole area of brain tissue that's being compressed and pushed in. We don't see it here, but it will affect the ventricles and any other subsequent structures below that level of bleeding and that compression. Okay, so this is exactly what I just said. Because of this blood, then you're going to have compression of tissue, you're going to have changes in pressure, and it will lead to cell death, or cell damage and or cell death. So in this picture, we're seeing a person who has had a craniotomy, meaning that part of the skull was removed. And the reason for that was, again, if I was sitting with you, we would talk about it and not ask you the questions, but the reason that part of the skull was removed was because there was either bleeding or some swelling within the brain. So the skull was removed in order to allow for the blood to be taken out, the excess blood to be taken out, and for the brain to have space to swell without the damage that would occur if the brain was swelling and pushing against the skull. So there is a clip here that we want you to watch. I'm not going to click it here. I'm going to put it off to the side, but when you click that link or that link for the craniotomy, it will show you an animation. It's not a real person, so you don't have to get queasy about it, but it's an animation showing a craniotomy, showing the damage that's there, how they cut through the bone, how they take that out, how they then evacuate the blood at the level of the above the dura and below the dura. And then in that video clip, they show the skull being put back, and that is not what they do anymore. They wouldn't immediately put that skull back. Typically, they would leave that skull off so that it would look like this gentleman, and you would see that indentation. and then that skull would be replaced later on, but not with bone. They would use a different structure. Okay, sorry, I just paused again. Let's see, let me just go back for a second. So there can be a craniotomy where when the procedure is done and the skull is immediately replaced if there isn't a concern about swelling. But typically in a traumatic brain injury, when there's more damage, that's when the bone flap would be left off to allow for swelling to occur. And that's why a person would be wearing a helmet such as the one you see in this picture. Okay, I'm just trying to advance the slide. There we go. Sorry, I went back too far. Okay, so this is another animation. Let's see, just a second. There's an animation that occurs in this slide, and in this one, we want you to watch the animation and then answer some questions. You're going to see an animation that represents acceleration, deceleration, movement, and injury. And so these are the questions that we want you to consider. So take notes as you watch this animation. And really important, you see in red, it says explain the diagnostic role of MRI and CT scan. So make sure that you do that. Okay, and in this slide, you see that when referring to neurological disorders that might occur with cognitive impairments, I mentioned before that when there's a stroke, for example, that's considered focal damage because you can see and sort of pinpoint this is the area where there was a blood clot or a constriction, and this is where the stroke occurred. It was in this hemisphere, in this lobe, so that's considered focal. You can also have injury that is diffuse. So we're going to talk about that a little bit more. So the type of cognitive impairment the person has will depend a bit on the distribution, on the severity, and on the underlying pathology. So back to the distribution, focal will be in one area. So as we mentioned, a stroke, a tumor in one place, there can be a brain abscess in one place. A penetrating injury could be focal. We mentioned that ice pick example. However, when you penetrate the brain in that way, because of the risk of infection and a lot of inflammation and swelling, then the damage itself is probably more likely going to be diffuse, but it could happen. Multifocal is where there are multiple instances. So let's say that a person had a stroke but they've had multiple strokes. So they had a stroke, 6 months ago, and now they've had another stroke. So that means that they have multiple infarcts in the brain. A person could also have some type of cancer that metastasizes to the brain, and they might have multiple tumors in the brain. That's what we mean by multifocal. But still, each one of them is this specific area of injury on the brain. Diffuse is where the whole brain has been involved. So when you think about traumatic brain injury, it's most often going to be a diffuse injury. Mentioned before, this diffuse axonal injury, which you would also see explained on the video of acceleration, deceleration type injury. This diffuse axonal injury means that throughout the brain, you have multiple axons that might be sheared because of this mass effect of injury to the brain. Also, hypoxic ischemic injury, if a person has had loss of oxygen, and the brain has been without oxygen for a period of time. So we might see that this could occur after maybe a person has had a major operation, and somewhere as, transitioning out of that, they might go into cardiac arrest and, completely stop breathing, completely stop, and there's no oxygen to the brain for a period of time. Any type of variety of different types of diseases or disorders that might affect the brain, like meningitis, for example, encephalitis. So where there's an infection to the brain would result in diffuse damage. And cerebral atrophy is something that we typically see in dementia. It also might be seen in other diagnoses. Sometimes you can see specific areas of atrophy, less common, but in an aging brain that has had dementia, you may see that there's generalized atrophy or shrinking in the brain, shrinking of brain tissue. So we mentioned that the distribution, we went through that, we said that the distribution can make a difference, also the underlying pathology. So is this malignant or benign? So if a person has some tumor in the brain, obviously if it's malignant, it's more malicious and it can be something that can get progressively worse. If it's a benign tumor in the brain, that's still a cause that can still be life-threatening. So benign just means it's not cancerous, but if it's in a certain area of the brain that's really dangerous, or if it's growing rapidly, then that can still be life-threatening. Also, in looking at underlying pathology, we can think about whether it's acute or chronic. So if this is something that is acute, like a person just had a stroke, but they are going to get better, there's going to be, starting to regain some function, and that person is on a trajectory where there's some recovery versus a condition that is more chronic. So you think about something like Parkinson's disease or Parkinson's dementia, which would then also be progressive and degenerative, as well as something like Alzheimer's dementia. And then for an infectious situation, we mentioned something like encephalitis or meningitis, which can be certainly life-threatening. And the key issue there is how quickly can that be diagnosed and treated. So it may be that it's reversible once the treatment occurs and all of the infection is taken care of. And obviously different types of things that can cause damage to the brain, which would result in cognitive impairment, that we've talked about many of these things. So this slide is just a repetition of that. One term that I had not mentioned yet was chronic traumatic encephalopathy, CTE, and we'll be covering that in detail later on. Other neurological conditions are listed here as well. Again, you may be familiar with MS or Parkinson's as a motor disorder, but they can also be associated with different types of dementia, as well as AIDS and Lyme encephalopathy, which can also result in cognitive impairments. A word again about cerebral atrophy, as we said that it can be diffuse, generally diffuse, mostly diffuse, but there are a few cases where it may be more focal or more prominent in certain areas. And the one situation that comes to mind is PPA, for example, where a person may not have had a stroke, but for whatever reason, and this was, one of the first cases that I saw where the CAT scan or MRI was showing some generalized areas of atrophy, and it was pretty specific to left hemisphere temporal areas for that individual. But atrophy is atrophy, or this shrinking or loss of cells. So the mass looks smaller, the tissue looks smaller. So it really is a loss of neurons as well as the connections between them. So the connections between them is important to note because as we talked about cognition, we were saying again, it's not just this area here and an area there, but if you think about something like attention, for example, the connections between all those cells is just as important. So this is showing you some examples of what atrophy might look like, and it can occur, as we said, in stroke. If a person has multiple TBIs, going back there, stroke, TBI, multiple sclerosis, MS, encephalitis, and other infectious diseases. And if you're looking at the A, B, and C, this is the same person over time, and you can see a difference in the healthy full brain. You can see some atrophy in B, so the shrinking of tissue, and then in C, you can see quite a loss of tissue. Let me take that back. I can't say with certainty that it's the exact same person. It could be just brain mass in 3 different stages. I'm sorry, I lost the reference on that one, so I'm not sure, but obviously you can compare and see the differences. You also see that the ventricles look so much larger because there's much less tissue surrounding it. So you also get a hydrocephalus as well, a change in pressure in the ventricles because of this decrease in muscle mass of the brain. Okay, so here's another one, and yay, here's the reference there. And so this is showing you the brains of different patients and also showing you differences in brain atrophy as well as what I mentioned, enlargement of the ventricles across time. And also highlighted here that these are changes in patients who have fluent primary progressive aphasia. So primary progressive aphasia is a form of dementia, so they are going to have cognitive deficits. Okay, that's it. Thank you for listening.